Hello and good afternoon, everyone. We're going to get started here with today's webinar. Hi, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Welcome to today's program. I've got just a couple of slides for introductions. So as you join today, your microphone or your phone was muted. We're going to use the chat function for any Q&As, any questions and answers. Please go ahead and type them into the chat, and we'll be able to get those questions addressed for you. This is being recorded, and the slides and the recording will be available on our website after we are done. I will be sending out a thank you email to everybody that is in attendance today with that information. You don't need to worry about writing it down or trying to copy it right now. This is a continuing medical education information. We've got our outcome objectives, the accreditation statement, relative financial relationship statement, and the attendance tracking. For our MDs that are on, you can get your CMEs, and we use the Cloud CME system here at the University of Arizona. That information will be in both the evaluation that will pop up after the session and in my thank you email. Everybody is welcome to get a continuing education certificate, and you can just respond to that email I send out and request that, and I will get that PDF for you. We have a standard disclaimer. And we'll go to the next one. This is our website. Please check our website for upcoming events and webinars. We've got quite a few more this month. Hopefully you'll be able to check that out. Again, I'll have this in my thank you email to everybody. And again, your opinion is valuable to us. Please participate in that brief evaluation. We take the information seriously that you give us. We take those suggestions, and that helps us come up with some additional webinars and educational events for you, our audience. So without any further ado, I'm going to go ahead and introduce Dr. Christy Petersen. She's going to be talking about teleaudiology at the Phoenix Indian Medical Center. She's the chief of audiology in the outpatient specialty services at the Indian Health Service in the Department of Health and Human Services. I'm going to go ahead and stop sharing, and then she's going to come on and get her file up. I learned about Dr. Petersen when she attended our council meeting, which happens to be next Wednesday. If you're interested in attending that, you can register for that on our website as well. And so we've got you want to switch your screen like we did earlier?
Yes, do that.
Swap your display. Yeah, that should do it.
All right, are we good on your side?
Oh, I still see the note part.
Oh,
that one more time.
It swapped on my side.
I got it to work earlier. Yeah, I still see the. I still see the.
Hold on, let's see.
You want to try it again? There you go. Let's try it again. There we go. Perfect. All right. So without any further ado, I'm going to let Dr. Petersen, take over the mic and briefly introduce share some of her experience, and we will get on with our presentation today. Thank you very much for joining us.
All right, good afternoon. Welcome, everybody. My name is Christy Petersen. I am the Chief of Audiology here at the Phoenix Indian Medical Center. I've been a clinical audiologist with the Indian Health Service for about 11 years now, so providing audiological services to over 220 different tribes in the Arizona, Nevada, and Utah areas. We recently started to push forward with some telemedicine, especially in teleaudiology. And so this presentation will have three parts, primarily going over indigenous population, their healthcare and hearing healthcare needs, and why telehealth is important. PIMC, Phoenix Indian Medical Center, specific audiology services, and then also teleaudiology put into practice through PIMC. So for disclosures, this material is based off of work that was supported with resources from the Phoenix Indian Medical Center, as well as the Phoenix area of the Indian Health Service. The contents do not represent the views of the United States government or the Indian Health Service. And again, I'm the Chief of Audiology here and clinical audiologist. So throughout this presentation, some learning outcomes that you will have. You should be able to list at least 3 different audiological services available through telehealth. You should be able to identify the difference between synchronous and asynchronous audiological services. And you should also be able to describe 3 healthcare issues or comorbidities with hearing loss. So, Indigenous country is in large part due to forced relocation of Indigenous communities. Most of these communities are located in extremely remote and isolated areas. Because of this, it makes finding sustainable, high quality healthcare delivery an ongoing challenge. This is why telehealth is so vital for our communities in Arizona and Utah and Nevada. So, what is telehealth? Most of us know what telehealth is, but to dive a little bit deeper, it's the use of electronic information to support and promote long distance clinical health care. And specifically through, IHS, we have the HRSA, which is the Health and Resource Service Administration, which helps, promote pushing these things forward when the government is not shut down. But types of telehealth, we have synchronous. So that's real time communication. That's when I can interact with a patient remotely, either through a video call, audio, or through messaging or chat. Asynchronous is going to be health information that is obtained and saved, and then it's submitted to a provider for future analysis or responses. This can be something like images, lab results. A lot of times we do this with different, not in audiology, but with ENT, we do this with imaging, CT scans that all get sent to a different provider. They analyze it and that gets sent back. We also, in audiology, have remote patient monitoring as well. So this is something that's collected and transmitted into a portal for that patient. Things like glucose meters, blood pressure monitors, for audiology, things like hearing aid usage, data logging, issues with cochlear implants, things like that. And then we also have M Health. So mobile health, you've got wearables, different healthable smartphone applications. On the market currently, we've got a lot for smoking cessation, fertility tracking, stress management. And with audiology, a lot of our hearing aid manufacturers, as well as cochlear implant companies, also have these smartphone applications that are used for that mobile health for our patients. So, why is this a vital service for Indigenous country? As I said before, the rural populations are extremely remote, and because they are so rural, they have an increased risk of chronic health conditions and are more likely to have great barriers to accessing health care. So, 40% of the United States Indigenous populations reside in rural areas. This geographic isolation is a pretty big barrier to receiving quality medical care. I know I see that on a day to day basis. And as a member of IHS, we are here to provide and utilize everything we can to give resources at a high level to these patients to make sure they are getting the quality health care that they need. So here's just a map to get an idea of the Indigenous population. This is from the 2020 census. This is the most current release of this data. But you'll see in the country, the really dark red, that's going to be where it's most concentrated with the Indigenous population. And then as it gets lighter and lighter, that shows kind of where we don't have as many communities. You can see a really high concentration of Indigenous populations in that Four Corners area. So northern Arizona, Colorado, Utah, New Mexico, and then a very high population in Hawaii as well. So we are going to zone in a little bit here and talk about audiologists and how this relates. So if we look at employment of audiologists by states, this is from the 2020 U.S. Bureau of Labor. This is showing, again, with that gradient color, the darker green, more employed audiologists, lighter green, less. And so that shows state by state that employment. And then by region, if we want to break it down, it shows, okay, well, Arizona back here, really dark green, but all of the audiologists are basically in that Phoenix metro area. So it really becomes concentrated into very small regions of each state where we have these hearing healthcare providers. If we do an overlay of the maps, you can see where the majority of that population, indigenous population, is in reference to where the majority of audiologists are. And there's not hardly any overlap. So the majority of those populations are really quite far away from where the majority of audiologists are employed and working. This is just another view to look here at the practice locations of hearing healthcare providers. This is usually also associated with ear, nose, and throat providers as well. So looking at the state of Arizona specifically, most of them are employed in that Maricopa County region around that Phoenix metro area, and the southern Arizona around Tucson as well. We have quite a bit there. But right next to it, we have that layout of the population.
Mhm. All right, and then I'll just say next for when we move forward. Thank you so much. Okay, thank you everybody for your patience. Our server went down at the hospital here. But here we're looking at the practice locations of the hearing healthcare providers and kind of mirroring that against the population by percentage by county for those indigenous populations. And you can see that, again, the majority of those practice locations are located in that Phoenix metro area and Tucson, southern Arizona. In contrast, the majority of the population percentage by county for indigenous populations is really heavily concentrated in that northern region where we do not have as many practice locations for audiologists and ear, nose, and throat physicians. Next.
Sure, no problem.
Okay, so zooming out and looking at this hearing loss and associated health issues, primarily in adults here. There is a big hype on the cognitive decline and dementia. So, and rightfully so. It has been shown that hearing impairment has been found to be the most prominent midlife risk factor for dementia. 55 has been the youngest average age that has been shown to be associated with that hearing impairment and high risk of dementia. The rate of cognitive decline slows after the start of hearing aid use, and we'll talk a little bit more about that. Other associated health issues with hearing loss include depression, reduced social participation, and other adverse effects on quality of life. A lot of times, individuals that come in with hearing loss are, it's such a big communication barrier, and they find themselves no longer being active in what they used to be active in, and no longer connecting with individuals because of their hearing loss. Whether it's embarrassing, whether they just, it just becomes too hard, too fatiguing. A lot of these patients just report that they are no longer participating in the things that they once enjoyed and feel isolated in their own home. Next. So they've done many studies on this. There was a big study in 2018 that was published, and it was showing that when hearing impairment or hearing loss is treated with hearing aids, it really supports the flow of cognitive decline. So this shows that with hearing aids, we have better input to, the ears. We keep that connection between the ears and the brain healthy, really reducing auditory deprivation. And so when we reduce auditory deprivation, that's protective for cognitive function. And it has this cascading effect where now also with the hearing aids, these patients feel that they can engage in things that they used to do before, better quality of life. It's also shown, that there's a reduction in reported depression, as well as enhanced self-efficacy. So a lot of times these patients, once they start, they go down the road of treatment of their hearing loss with hearing aids, they now feel much more able to kind of, much more confident in their abilities to accomplish the tasks and things that they used to do. Next, please. So breaking down the different types of hearing loss, just briefly, we won't go too deep into the weeds here, but we've got three main types of hearing loss. So one type of hearing loss is conductive. These are pathologies that are affecting the outer and the middle ear. This can be something like atresia or microtia, so a very small ear, maybe no ear canal at all. Other things like otitis media or cholesteatomas, different head traumas. These are things that can contribute or be a driving factor for conductive hearing loss. Sensory neural hearing losses, those are pathologies affecting the actual cochlea and the subsequent structures on that auditory pathway. So with sensory neural loss, this can be something that is age-related presbycusis, noise-induced, things like acoustic neuromas that are pressing on, the hearing nerve. And we also see a lot of what we call idiopathic sudden sensory neural hearing losses. And lastly, we've got mixed hearing losses. So a mixed hearing loss is both conductive and sensory neural. This is something where you have chronic middle ear disease plus noise exposure potentially, or something like otosclerosis. So you've got a mixture of the two things kind of coming together with the middle ear as well as that inner ear. Next. So diabetes and hearing loss, and this is really specific to our indigenous population. Uncontrolled diabetes is a major risk factor for hearing loss. So through a lot of research, they have shown that the association between diabetes and hearing loss, an individual is twice as likely to have sensory neural hearing loss than an individual without diabetes. And this isn't influenced by the type of diabetes. So, diabetes type 1 or 2, except for the rare maternally inherited diabetes. There's some mitochondrial genetic mutations that can change things there. But any uncontrolled diabetes is showing that people who have diabetes are twice as likely to experience some form of hearing loss. Persons who are pre-diabetic now have a 30% higher rate of sensory neural hearing loss than those with normal blood sugar levels. And in rare cases, people with diabetes are more likely to develop malignous otitis externa due to infection and, the reduced healing abilities when we have that uncontrolled diabetes. Next, please. So this is looking at our department here. The PIMC audiology department consists of 3 audiologists, 1 audiology technician, and 1 program support assistant. So up on that top, those are our 3 audiologists, myself, Dr. Himmelstein, and Dr. Schneiderman. And below, we have our audiology tech, Renee, and our program support assistant, Ophelia. Fully staffed, we are 5 audiologists, 2 techs, and 1 program support assistant, but currently we are going on 3 of us right now. And you'll see that we are with the specialty services clinics, and we provide services not only to the Phoenix area, we are based out of Phoenix, but also to field clinics. So we travel to Parker Indian Health Center, Fort Yuma, Southern Bands Health Center, which is in Northern Nevada, White River Indian Hospital, Sherman Indian High School in California, Reno Sparks Tribal Health Center, and the Yavapai Apache Health Center. To date, PIMC has provided hearing loss treatment to patients from over 220 tribes. And coming up, I will show you a little map of what we have here. Next, please. So this map is showing the United States broken down into the Indian Health Service area map. So they map out the United States based on different areas. You can see Portland area, Billings, California, Phoenix, Albuquerque, Oklahoma. Nashville area is basically the entire eastern United States. But we'll focus in a little bit closer here. Next, please. So this is our Phoenix area, and this is what our audiology department covers. You can see it's all of Nevada, the majority of Arizona. We do have some in that northern corner that is Navajo area. Navajo is not covered under federal services. They are tribal, so they are a little separate from us. And then you can see a little bit in Utah. Riverside in California is technically California area, but they are, for audiology, covered by us. Next, please. So how do we do telemedicine in audiology? So here are some examples of teleaudiology. For synchronous, we can connect with patients through manufacturer remote programming platforms for hearing aids to conduct programming changes. We can also call patients on the phone and do follow-ups through the phone. And we have different platforms where we can actually complete diagnostic testing through a synchronous connection. For asynchronous, this is where patient reports difficulties. They can do it through a smartphone, and that gets sent to us in a file requesting different adjustments for their hearing aids. This can be something like automated audiometry. So there are some offices where they've got a little tablet where a patient will just do an automated hearing test, self-led, and then that data will get sent off to an audiologist for analysis. Or video otoscopy. So, they're in to see a primary care provider and their eardrum or middle ear or, external, ear canal looks funny. So the provider may have the ability to take that picture with a video otoscope, save that image, and again, send that file to an audiologist or an ear, nose, and throat physician to analyze that. We also have remote patient monitoring. A lot of times this comes in the form of data logging or wear time, whether that's with a hearing aid or a cochlear implant or a bone anchored hearing solution. And that's something that is just constantly tracked on that patient. And then mHealth. So with that mHealth, this is something that is usually through a smartphone application on the patient side. And this can do things like make hearing aid adjustments, by the patient through that app, or they can run self-checks on their hearing aids or cochlear implants through that application. And a lot of these applications are also starting to take on different functions like wearables so that they can get wellness scores. So not only will it show steps and activity levels throughout the day, but it'll show different scores for how long they were wearing their hearing aids and how long were they in difficult listening situations, giving just patients different targets to work towards. Next, please. So before PIMC put teleaudiology into practice, we wanted to consult with other individuals that had more experience in telehealth services. The VA in particular had I believe it's 2011, they launched about 11 different community-based outreach centers to start doing some telehealth. And so audiologists within the VA kind of got to be on that front line of doing teleaudiology. So here we just have a list of individuals that we collaborated with pretty closely. You can see in Ontario, Canada, Bill Campbell, for a long time, they've been doing a synchronous testing for infants. So infants that fail their newborn hearing screening, they're able to do remote diagnostic testing to make sure that we can identify hearing loss in those babies quickly. Jessica Messermitz, University of South Dakota, again, she also did that testing for infants with technicians. And then we've got Courtney Karen here. She was at the VA at Nevada Healthcare System, and they have a full telehealth room with synchronous telemedicine that they use with technicians. And then Samantha Kleindens-Robler, she had developed a telehealth cart. Now she was working in a really rural part of Alaska. So a lot of this was asynchronous. Clinicians out in these remote areas would get that data on this telehealth cart and then send that data in a file to audiologists in less remote areas to do the analysis. Next, please. So this is just an outline of what diagnostic services we actually offer at Phoenix Indian Medical Center, and then I've identified which ones of those that can be that were provided through our teleaudiology program. So we do comprehensive diagnostic testing, which includes testing the middle ear, as well as conventional pure tone testing, so finding the threshold of the softest sounds one can hear. Word recognition testing, speech and noise testing. Those are all things that we were able to do through our teleaudiology program. We also provide visual reinforcement audiometry or hearing tests. So this is for kiddos. So when we have kiddos that are young, usually under the age of 6, we have different techniques in terms of testing these kids to make sure, to find their hearing status. That is not something that we launched through the teleaudiology, mainly because we needed to train some of the technicians a little bit further. It's a little bit more complicated setup when you're working with those kiddos. We do screenings for retrocochlear pathologies, otoacoustic emissions testing. So these are things that are testing their evoked potentials in the brain, but they're things that we can test through that teleaudiology remote system. And then again, we've got some vestibular testing, hearing monitoring services, which is basically your annual hearing test or aided testing for individuals. We do hearing tests for employers or academic requirements. We take care of newborns and do all of the diagnostic evaluations. We complete tinnitus assessments for individuals with tinnitus, cochlear implantation. We do candidacy evaluations as well as cochlear implant activations and mapping, and bone conduction implant candidacy evaluations, as well as bone conduction implant activations and programming as well. Next, please. So that was just our diagnostic. In terms of treatment, what we provide, we do hearing aid evaluations, fittings, and follow-ups. Through our program here, we provide patients with amplification at no cost to the patient. So we have contracts with every hearing aid manufacturer, and we are able to order the top tier technology and provide those hearing aids and accessories to patients at no cost. We also are able to do assistive technology evaluations, fittings, and follow-ups. So for individuals, maybe something like a vibrator that goes under their pillow, and when their alarm goes off, the pillow vibrates, or something that, your smartphone can connect to your doorbell and that will go through your hearing aid. Again, cochlear implant activations, bone conduction activations, assistive technology. We take care of walk-in, mail-in repairs, troubleshooting services, tinnitus management, which is typically a combination of counseling and hearing aids, assistive supports for schools. So we take care of 504 plans, IEPs. We work with educational audiologists, teachers, and other school members. And then subjective and objective testing to evaluate treatment progress. So that would be something like aided testing. How is this patient doing once they have their hearing aid or their cochlear implant? And again, on this screen, I've shown what our treatment services are, and then those that are available through telehealth. And then the little asterisk shows the ones that we were providing previously through our program, which I will go further into towards the end of the presentation here. Next, please. So how did we get to our patients, or how do we get to our patients? Without telehealth, we drive or fly. Our flight contract was discontinued in 2021. So for the last 4 years, we have been driving out to these remote areas. So it would be like a 4-hour drive, have clinic, 4-hour drive home, making for a pretty long day. With the flights, still a long day, but not quite, the drive was a little bit different, but we've got these little puddle jumpers here. And flights are actually resuming this week. So we will start flying on Friday again. We'll see how that goes. But that is how we get out to these remote areas. Next, please. So in order to make it more efficient providing these services to our patients, we wanted to kick off a teleaudiology program at PIMC, providing synchronous services, remote patient monitoring, and that mHealth that we discussed. Next, please. So these are examples of appointments that would be just through the telephone only. So we can do hearing aid follow-ups, going over with the patient, how they're doing with their instruments, assisted listening devices follow-ups, family and caregiver training, so going over how to take care of the hearing aids, insert the hearing aids, remove them with families and caregivers, educated and work-related follow-ups, oral rehabilitation, so counseling, and case management. Next, please. For our telemedicine appointments, which is billed a little differently, we would do hearing aid follow-ups. Again, similar things here, but these are things we also add in real-ear measurements, hearing aid programming, comprehensive diagnostics. So these are examples where we would actually be in that synchronous mode with the patient, having a video oftentimes so that we are working one-on-one, essentially face-to-face with that patient. Next, please. Now, these are just little examples to show if we're doing a hearing aid or cochlear implant remote programming. It shows the provider view and the patient view. So that patient view would be like on their smartphone. And the provider is looking at the program and the software and speaking to the patient and able to see the patient, and patient is real-time experiencing those changes or those programming adjustments in their hearing aids or their cochlear implant. Next, please. And then that mHealth. So these are those smartphone applications that I was discussing a little bit earlier, where the hearing aid actually has wellness scores and is similar to a wearable and tells patients their activity level, et cetera. So patients can set their own goals and see how they're doing with their hearing aid use. Next, please. So we launched a teleaudiology clinic at the Hopi Healthcare Center. These services were discontinued, just a change in the clinical director and the tribal, the funding, they decided to discontinue the services, but this was the first teleaudiology program in Indian Health. So we were pretty excited to get that kicked off. Next, please. And this will show you a map. So Phoenix, that's that star in the center, and then where that other star is, that's Hopi. So that's about a 4.5-hour drive from Phoenix. And we had a lot of patients with about a 6-month wait list needing to see us, and we were only able to travel out there by plane or car about once a month with our provider schedules. Next, please. So launching that teleaudiology program, we had a proof of concept, and we wanted to improve that access to care and reduce the hearing healthcare disparities. Again, they're in a really remote location, especially specialty services are very hard to come by when you are that remote. And this would also reduce the economic and transportation burdens. So whether that is the provider driving out or flying out, or the patient making a 4.5-hour drive, for a 30-minute appointment in Phoenix, we really wanted to reduce that burden on the patient. Next, please. So what were the logistics? So in order to complete this, we had to have a telehealth technician, someone that we would train in Hopi to do the setup and get it connected so that we could work face-to-face with that patient. We also needed a web-based platform allowing for that remote control. And the most important thing is we needed communication and buy-in by the tribe as well as that service unit. Next, please. And this is just a list of the equipment that we needed in order to get this done. So this is the equipment that would complete the diagnostic testing for inner ear, middle ear, video otoscope, and the computer. And just a little disclaimer, the materials for part of our program were purchased through the CARES Act funding and the Ear Foundation of Arizona and donated to the PIMC teleaudiology program. Next, please. So there's a picture of the booth setup once it was all done. The patient would sit in that center chair. You can see there's a touch screen to the right. The health technician would set that up so that patient, that is where they would be talking face-to-face with the audiologist in Phoenix. Next, please. These are just going to go through quickly the different equipment that we had in that booth. So this is our Titan. This does middle ear assessments, otoacoustic emissions, auditory reflex thresholds. So all inner ear as well as those evoked potential screening for DPOAEs for kiddos. Next, please. This is the Viat. It is our video otoscope. It can capture videos as well as still images that can be synchronous or asynchronous. So again, this could be saved and sent as a file if we were not in a synchronous mode there. Next, please. This is our monitoring camera. It had a 360-degree from remote control. So this is so that the audiologist could move that camera and make sure, okay, is the patient set up correctly for testing in the booth? And we'd be able to really monitor that remote testing. Next, please. So we have the touch screen within the booth. That would be the patient's view. Next, please. The hearing aid cart, and so this has everything built in with the hearing aid programmers, Bluetooth, so that those could all be connected to our computer and then remotely worked on by the audiologist in Phoenix. Next, please. This is our audiometer, so this does the diagnostic testing for the inner ear, so the thresholds, different frequencies. It also does real ear measurements, and that is a measurement to make sure that the hearing aids are doing what we want them to do, verifying them using a little probe in the ear canal with the hearing aid on. Next, please. So this is a video. I'm not sure if it'll play for you guys, but this does just show a full view of the booth, if that video plays. And then next, please. So how did we achieve that remote connection? We went through a WebEx platform to get that remote connection. And then NOAA, which is a centralized network server that has our database of hearing audiograms, so the actual data, as well as hearing aids, hearing aid programming systems. And then we had a PC-based testing system for all of the diagnostic equipment. Next, please. So it's very simple. It took 3 clicks to enter an appointment platform. So we would teach the technicians how to enter that. They would just 3 different clicks on the outside PC desktop, and that would connect us to the inside of the booth. Next, please. Again, this is just showing that view from our 360 camera there. Next. And then showing video otoscope. So this would be an example of what that video otoscope would show real time. We can say, technician would put it in their ear, we'd say good, they would take the picture, snap that picture, and then that would get saved in our database. Next, please. Tympanometry, this is measuring the middle ear status. Again, that would run automatically, letting us know, is the eardrum intact? Do we have a perforation? Do we have, occluding cerumen, anything like that? Next, please. And then we're also able to measure acoustic reflex testing. So this will check middle ear status, the cochlea, as well as the integrity of some of our nerves, brainstem structures, the pediis muscle. So this really gets into, if we're trying to rule out a retrocochlear pathology. Next, please. And then basic audiometry, hearing sensitivity, comfortable levels, uncomfortable levels. So things that we use in order to program and treat program hearing aids and treat that hearing loss. Next, please. We are also able to do speech audiometry. This is making sure that, patients, whether they have auditory deprivation, maybe they aren't able to understand speech and make out what they're hearing even when they have the audibility. We can also test in noise to see how are these patients doing in noisy situations, where do they fall apart. Next, please. Real ear measurements I briefly spoke of. Again, this is finding that prescriptive hearing aid fitting using the unique anatomical characteristics of that patient's ear canal. So we use it with a little probe, hearing aid is in the ear, we're able to measure and make sure that we are meeting all of the targets. Next. So that was our program there in Hopi. Again, it was discontinued. Now, all of that equipment is currently pending a new location. The different service units are working with each other to see who wants us. But it was launched at the end of November 2022. We had a total of 11 and a half full clinic days. So we would have a half day in the morning, a half day in the afternoon, once a week, and for one provider, and we'd rotate between providers. It worked out really well. We completed our 6-month wait list in about 3 months, and the total patients scheduled for our telehealth appointments would have taken more than 3 times the duration it took for us to complete those telehealth appointments with patients. Patients really appreciated this availability. They didn't have to make that drive. We didn't get any reports of, concerns of the quality of care. They were satisfied with the teleaudiology. The health technicians had a wonderful time learning something new and kind of adding a skill set. And it had improved provider satisfaction. So no longer were we doing these long days of driving, 3.5 hours, doing a full clinic and then driving 3.5 hours home. We would just come to work and be able to see our patients, and it was quite nice. Next, please. But there were areas for improvement and development. So increasing leadership awareness, making sure you really establish a collaborative agreement prior to the initiation of our services. That is super important to keep that program going. Also finding a system to determine the community need and the consultations. So the telehealth clinic, they got to the point where, no patients were getting scheduled. So we really wanted to find a better system to make sure that we were getting patients that needed to see us scheduled. And, they would report a high rate of patients wanting to come in, but that wasn't ever reflected necessarily in the schedule towards the end of that program. More areas of improvement: show rate. We did have patients that wouldn't show their appointments, which is inevitable in healthcare. And then a training plan for those health technicians to really advance them and increase their competencies. And lastly, transition plan and equipment capability to achieve more goals to really further total telehealth. Next. So projections for PIMC audiologists: within the next 10 years, we are looking to expand to 27 audiologists, 14 audiology technicians in a new hospital. We would like to really push teleaudiology Indian Health Service wide, so really spreading that across the country. That would include a technician training program, teleaudiology booths. This would be able to cover adult and pediatric testing and remote fittings and follow-ups for hearing aids and implants. Again, the newborn hearing testing and teleaudiology asynchronous care. So providing, the automated audiometry or the files of videotoscopy that are then sent to an audiologist for review. Next, please. And then, do we have any questions?
All right. Can you hear me?
I can, yes.
All right, great. Okay, we had a little issue when we were getting you back on. So there's a question in the chat. When you're serving hard of hearing people virtually, is captioning actually provided, or is that something that's utilized?
Yes, that is a wonderful question. So we do have tablets that have a live transcription. So for those patients that were hard of hearing and were not able to hear us through, the speakers in the booth would pick up, would transmit, our voice. But if we had plenty of patients that did need that captioning, so we had tablets that have a live transcribe. We'd turn that on, and that way they would real time. We'd have that conversation, and it would be transcribing what we were saying.
Gotcha. Okay. And I guess the kind of a follow-up question was, yes, if the patients, the hard of hearing patients, are informed that there is that captioning option for them, that they know how to access it with the live transcript.
And a lot of our patients, we counsel, once we know what their hearing status is, we counsel them and have a lot of different options for them in terms of there are a lot of free options for captioning, telephones,
Okay.
things like that we provide them as well.
Okay. So I don't know if we were able to get that last question. Is the live transcribe on the tablets is HIPAA compliant?
So the live transcribe, it's HIPAA compliant in that it is in a booth that is, again, it's real time. As soon as that patient is done, that tablet is, like, once the conversation's done, it is erased. So none of that's actually kept. And it's not
Okay.
able, the only people that are seeing it are the patients themselves.
Okay, great. All right, that looks like I think we got all of our questions that were in the chat, Dr. Petersen. And with that, we are right on schedule, even with our little technology issue there to begin with.
All right.
So,
well, thank you, everyone. Again, my apologies for that technology issue here at our hospital, but I appreciate everyone hanging tight.
great. So thank you everyone for joining us. And I have my own echo here. Anyway, so thank you again for joining us, and I hope that you will join us again. I will be sending out a thank you email to everybody with all that information that I mentioned at the beginning, and then you'll have the link to be able to look at the slides that Dr. Petersen had shared with us, and hope to see you on a future webinar with us. Thanks, everybody.